Hi, my name is Paul Burgess. I'm a public health physician from Australia, and during the 2014-15 academic year, I was a Harkness Fellow in Healthcare Policy and Practice based at the McColl Centre for Healthcare Innovation, Seattle. I was sponsored by the Commonwealth Fund, and this presentation today summarises my work during that year. It's entitled Third Space Healthcare, and what I was looking at during my Harkness Fellowship was how innovations that were pioneered for vulnerable populations are really shaping the future for primary care delivery in the US, and by extension also in other countries. As a public health physician, I'm driven by equity and efficiency, and for the last 14 years I've worked with Australia's most vulnerable populations. Vulnerable populations are important to health systems because they teach us how to deliver population health. As a background to my project, we know in the US health inequalities are pervasive, persistent, and extraordinarily expensive. Levice and colleagues estimated that the annual cost was more than $309 billion a year. Of course, the Affordable Care Act was enacted, and in part of that there were wide-ranging reforms which were targeted about tackling access to care and hopefully health equity. We saw a massive expansion of Medicaid, with some 17 million at least newly covered. And there's also been reform to the service delivery system, particularly the patient-centred medical home. Both those two reforms were key to increasing access to care. At the same time, we know the primary care sector in the US is under stress, struggling to adapt to complex demands, patients with more complex diseases, and a complexity of administrative components. So these reforms created better access, and the patient-centred medical home accreditation was part of that as well, part of the key access improvement. But access probably is not enough. For example, a patient-centred medical home can qualify as a level 3 medical home and still not do much in terms of health equity. Vulnerable populations are wide-ranging in our conception of them. It's important to realise that all of us have the potential to be vulnerable at some time in our life, either through bad luck or misadventure. The definition used by ARC is those who are made vulnerable by their financial circumstances, place of residence, health, age, personal characteristics, functional, developmental status, ability to communicate effectively, and the presence of chronic illness or disability. This is a very wide-ranging definition that we've used for this project. Our research question was how have healthcare organisations extended upon the medical home to proactively identify and address the needs of vulnerable populations. Another way to express this, and for those of you familiar with Amartya Sen's work on inequality, will recognise the key terms here. What capabilities and functions have been developed to achieve better health outcomes for vulnerable populations? Our approach to this work was a multiple case study design. 4 organisations shown on the right here participated in this work. The sample, as you can appreciate from these organisations, was for maximal contextual variation, and these sites were chosen based on expert consultation of leading health researchers. We used Amartya Sen's inequality theory to drive this research, and a definition of a case to study was a healthcare organisation that, in addition to implementing a medical home model of care, had documented success in achieving the triple aim of better care, better population health, and lower costs for the vulnerable populations that they were caring for. The 4 participating organisations were quite diverse. Community Care of North Carolina is a public-private partnership serving the Medicaid population and the aged, blind and disabled. HealthShare Oregon is a Medicaid-specific accountable care organisation. They call them coordinated care organisations, and this one is based in the Tri-County area in Portland, Oregon. The Vermont Blueprint for Health is a statewide multi-payer initiative that covers the entire population. And South Central Foundation is an integrated health system spanning primary care, acute care, but targeted at the Alaskan Native population. This is an integrated health system. The analysis of this project was using rigorous case study methods that you can see here. Complementing 4 case study site visits, we completed 62 interviews, which encompassed 114 respondents. Importantly, respondents covered a wide spectrum across the entire health system, from funders to the frontline staff, executives in these health systems, doctors, external stakeholders and patients. Altogether, there were 114 participants. A key finding to emerge, and that was emerging across all 4 sites, was this concept of a third space in healthcare delivery that had been developed. In between the core primary healthcare team, which traditionally is the doctor, the medical assistant, the nurse, and the rest of the health system, these all 4 organisations had invested in building integrative capacity and functions. There was a suite of capabilities and functions around the primary healthcare team. And the 5 key findings were community development, human resources, technical assistance, data analytics, financing and incentives. And we'll go through those shortly. Firstly, however, I'd like to unpack the concept of the third space. Primary care is drowning in complexity in this country, as it is in many other countries in the OECD. Complex comorbidities, including mental health and addictions, administrative complexity and time pressures running a small business, and primary care is constantly trying to come to grips with the social determinants of health, which are felt sometimes to be beyond the influence of the primary care provider. These are things like employment, where people live. So the third space really are augmenting capabilities and functions that are built around the primary care team. These are things that primary care rarely gets to, and these are vital capacity building elements that are now being built by these organisations. First of all, there's a big emphasis on doing a population needs assessment that accounts for some of the social and cultural drivers of ill health. There's been a lot of attention to making practice more efficient, redesigning the workflow, and expanding the team. The notion of what constitutes a primary care team in these 4 sites has really been expanded dramatically. We now see social workers, we see master's level psychologists, we see pharmacists, we see mental health nurses, we see community members, community health workers, representatives from peer organisations such as the Urban League, all becoming part of the core primary care team. But that is in response to the needs identified in a population needs assessment. We see great attention to managing populations through managing panels, and where individuals need it, intensive case management. And importantly, we're seeing really strong inroads into building community linkages, linking with community services, and bringing those right into the primary care practice. All of this is underpinned by rigorous data and analytics that are required for learning and for constant improvement of the health system. The impact of these capabilities and functions on primary care is very impressive. What I see as a public health physician is technical and allocative efficiency being dramatically achieved. This is another way of expressing the triple aim. The 2 quotes on the right-hand side are illustrative from the interviews of what this third space entails from people in that space. I wanted to talk briefly about the community development that is happening in these organisations. What's being built around primary care is an accountable community of care at optimal scale. What I mean by optimal scale is that this is a defined service population, whether that's by geography or a specific vulnerability. And the other metric of optimal scale is the ability to sustain productive working relationships, because a lot of this really important work is done through interprofessional learning, interprofessional relationships, which we will discuss shortly. All 4 organisations had developed a deeper contextual understanding of patient needs, really getting closer to their patients and their problems and understanding their world from their shoes. The governance of these organisations was very impressive. They have participatory governance models bringing in key stakeholders from the community. These could be hospitals, these could be social service providers, public health providers, but importantly also includes community members and consumers within the health system or customers of the health system. These are helping set strategic direction and establishing a population health narrative that is managed through this third space. A really important learning here is that these are not command and control systems with vertical command about how to deliver healthcare. There's regional autonomy where geographic regions or services providing care to specific populations are encouraged to be autonomous, to use all the resources at their disposal while following the population health narrative set by the governance organisation. So this has been quite empowering for these organisations and has led to sustainability. All services had experienced redesign to address the identified needs of the population. There's a big move for co-location of services, particularly behavioural and mental health integration within the primary care team, using effectively warm handoffs to minimise fragmentation of care for the patient's perspective. There's been very strong linkage with community resources and leverage of these fully to meet all the patient needs, and a strong effort to work beyond the four walls of the primary care practice. All four sites have a strong presence of outreach case management, intensive case management for the people who really need it, and this has been very effective to drive down the costs from high utilisers of the health system. Interestingly, there was also strategic investment in vulnerable communities. This was in terms of employment, particularly employment of community workers or peers from community-based organisations. But in some cases, there was also a sense of rebuilding community for very marginalised populations. These were purposeful efforts to reintegrate people into community, teaching people how to be part of a community again. And this was leading to impressive gains in terms of people's self-care and their health literacy. All four organisations had realised that human resource management needed to be improved. All had developed strategic improvements in this area. There was a great deal of intentionality about integration in terms of choosing the right person to bring on to the team. So all four organisations were using behavioural interviewing. That's asking questions like, tell me about a time when you did this. What was that like? Importantly, the staff that were hired had to be change ready. They had to be adaptable to change and ready to change because the realisation was these services all needed to constantly improve to deal with the health needs that they needed to. All four organisations had very scrupulous attention to onboarding and aligning new staff hires with the population health narrative that was decided for the organisation. In two of the case studies, emotional intelligence was formally fostered by using proprietary products, business management products. All staff were given time and space, but importantly, the expectation to innovate constantly to build and improve the health system. Success in these organisations was driven by relationships, both at an interprofessional level, but crucially with patients themselves. This led to building the concept of teamness and feeling a shared mission and purpose and sustaining relationships between providers, but importantly with patients, really building a trustful therapeutic alliance that really made impressive health gains. A great deal of attention had been put also to technical assistance. This had to be provider-centred. You had to start where the primary care provider was receptive and ready to start. Constantly, interviewees in this work talked about it like behavioural or motivational interviewing with patients. You have to start where the patient is. The same analogy was applied to primary care practices. You have to start where the primary care provider is ready to work. So this was, again, a relationship building exercise, but the scope of work that was done in technical assistance for primary care practices encompassed case management and linking with community resources. These are the things that GPs or primary care physicians feel they don't have time to do. There was a great deal of attention to service redesign to make the workflow better and easier for the primary care core team. And this also included quality improvement work and rapid cycles of quality improvement. These were all key facets of technical assistance that led to impressive health gains for these populations. This third space also encompassed this learning organisation concept. So these organisations really functioned like innovation platforms. So people had time and they had the resources to apply for innovation grants to try new services or to improve services that were there. They hosted collaboratives, But also importantly, they were able to disseminate learnings within networks of providers so that learnings could be rapidly uptaken by other providers in an area. And this is really an impressive way that things were scaled up. Learnings were actively applied across a network of providers. Underpinning these successful organisations was some really rigorous data and analytics. There is an impressive array of innovative use of existing data, so using claims data from all payers and pharmacy databases. Also data that's collected by federal mandate. For example, following 9/11, hospital admission data is mandated to be reported in terms of bioterrorism surveillance. So these organisations, at least in one case, were able to use this data to real-time track admissions of their patients into hospital and out again in terms of managing their transitions of care. Data really is a foundational stone of the third space. It's needed for identifying needs within the population, for quality improvement, but also to manage the population as a whole. And this is increasingly being used in ever more sophisticated ways. Particularly in one of the sites, they were using some predictive analytics to look at patients that were impactable. So patients that would be a good spend in terms of doing active case management based on their health profile. And interestingly, in collaboration with public health agencies, increasingly there is health mapping in terms of mapping social indicators and health indicators to look at community level interventions as well. This is true collaboration between the primary care system, public health systems, and other community and local governments. Finance and incentives in the US is complicated. I come from a single payer country, and I found this almost bewilderingly complicated in this country. However, 4 organisations had 4 funding models, and there were some key themes and learnings to emerge from the financing of these health systems. First of all, a multi-payer system or integrated health system funding enables a population health approach. And this is the strongest way to fund this third space of healthcare delivery, collaborating with primary care and the rest of the health system. Funding only on a Medicaid basis leads to targeted high utiliser or hotspotting approaches. And really this isn't reaching the entire population, you're really just reaching the people that are costing you the most, and you're unable to turn off the tap of people coming down the pipeline that will cost you more in the future. All 4 organisations, if you look at their budgets, had increased social spending. But interestingly, this was on linkage, using the resources that were already there, not direct delivery of social services. For the intensive case management that was so successful in these organisations, there was a recognition that this had to be free from any obligation for fee for service or time constraints, because what was important to drive health gains here was building trust and building relationships. Incentives in these organisations were almost entirely non-financial. They included transparent reporting of performance to primary care teams, and also providing the extra team members around primary care to give them support with technical assistance and case management. These were strong incentives that built on people's internal desires to do the best they can for their patients. Patients in these health systems experienced transformational care, and it was a real joy to be in the room seeing what care was delivered to these patients. Dependency was not an issue. People experienced empowerment and activation, development of knowledge and skills and confidence to control all the issues and to contact the agencies they had a right to contact but not the confidence to contact. A lot of these vulnerable populations had been traumatised, including by trauma via the health system. So a big part of building trust and relationships was, for some of these patients, learning how to trust again, not to feel let down by the health system, which built a lot of success in terms of ongoing health outcomes. This is all built on the fundamental relationship building between the patient and the primary care team. Of course, in these systems, patients expressed high satisfaction and a noted difference in these health systems compared to healthcare they received previously. For providers, these systems were game changers. They all reported greatly improved satisfaction or joy in practice. This has been called by Tom Bodenheimer the quadruple aim, to build on the triple aim. So providers saw reductions in waste, fragmentation and duplication. However, there were some tensions here for systems that were only Medicaid funded or Medicaid targeted. The innovations that were developed for vulnerable populations, providers intuitively applied those across the entire panel. All the payers were covered by the improvements in care. So in some regards, some private health insurance companies, for example, were getting a free ride. They weren't contributing to these programs, but their patients were benefiting. Practitioners wanted case management for their entire panel, not just for some payers or narrow eligibility criteria. Practitioners could see the patients that would cost more coming down the pipeline and wanted to intervene earlier. But in the cases where there was only narrow eligibility criteria, felt this was a real barrier. On the positive side, however, with these systems where patients were getting all the needs attended to, providers talked about patients actually being positively geared. They would come to the health consultation ready to talk about their health because their distracting social demands had been dealt with previously. Practitioners describe this as patients that have been failures are no longer failures. Of course, a big part of the satisfaction and the joy in practice with these vulnerable populations was actually seeing the better patient outcomes. However, there were some barriers. Some of those have been widely articulated and are commonly recognised. You can see at the top of this slide. New barriers are emerging, so interference in these health systems, carving out parts of the health system to give to a managed care organisation, for example, behavioural health. We know this leads to cost shifts and fragmentation in care. So it's a real emerging barrier that this carve-out should be resisted because it actually costs more. In some sites, there's been an aggressive takeover of primary care by hospital organisations. And this is seen as a barrier because when you subjugate primary care to a hospital system, the internal motivations and the will to improve sometimes dissipates. It's also widely appreciated that hospitals aren't good at population management. Another barrier was unsophisticated Medicaid contracting. So by that, interviewees described perhaps the need for Medicaid to have more accountability in terms of what they were trying to get for their dollars that they spent. In conclusion, the quadruple aim for vulnerable populations in these four health systems is being achieved. It's being achieved by building accountable communities of care around primary care, really based on professional relationships and relationships with patients, but importantly, activating and levering resources within the community to service all the needs of the vulnerable population. Improvements are being achieved by maintaining a focus on the primary care team and equipping primary care teams for the tasks that 21st century healthcare requires us to do. So that's the right team, having the right skills, the right roles, and importantly, the right personalities to do this work. Data to learn and to manage populations is just crucial, and the technical assistance to help busy providers navigate these changes and to start delivering population health. Importantly, a customer focus is a key part of this success, and the capability to address customers' issues through empowerment, problem solving and advocacy, so teaching patients how to care for themselves and how to trust the health system again. In terms of policy implications, there's some key ones here. There are many, but one of the ones I wanted to talk about was firstly, the multi-payer commitment to the third space is really necessary. Firstly, to align with the patient-centred medical homes panel commitment. You have to provide these services across an entire panel to satisfy the provider, but also the provider's panel. The multi-payer commitment really is essential to achieve true population coverage, and this leads to maximising efficiency and effectiveness of these support functions around primary care. Data sharing and information sharing is absolutely vital to success. There are some barriers for free flowing of health information within the US health system, and some states are making inroads into trying to reduce these barriers. However, there are some barriers between sharing between health organisations that may need political leadership to perhaps compel participation, because data is so important to identify needs and respond to patients in a timely fashion. Certainly, integrated health systems have advantages of having all that data at hand, but the non-integrated systems probably will need the political leadership to make this happen. Large hospital takeovers of primary care practices really poses some risks in terms of the effectiveness of primary care delivery, not only to vulnerable populations, but to population health in general. There is a real risk of conflict of interest with and service duplication in terms of duplicating case management services, or the push for primary care to reduce numbers of referrals to specialists and hospitals. This is an area that could be a conflict of interest. Subjugating primary care teams came out of my interviews as a real risk as well. If you are now working for a hospital system that just doesn't get it in terms of population health management, some of the impressive gains that have been described in these 4 organisations could be lost. Importantly, a really strong take-home message here that came out of this work was that primary care is sustainable, it is efficient, extraordinarily efficient, and can be very rewarding if well supported by these support functions around their team in the third space. In terms of acknowledgement, I'd like to acknowledge the team at McColl Centre for Healthcare Innovation, which is part of Group Health. My mentors were Michael Parchman and Ed Wagner. And I would also like to thank the 4 case study sites that participated in this work. Thank you for your attention, and if you would like to contact me for any further information or to discuss these findings, you can see my email address on this final slide. Thank you.